I am Tometta Cozart, and I would like to welcome you to Advancing Racial Equity in Epilepsy. This is in observance of the National Public Health Week, and this is hosted by the Epilepsy Foundation. I would like to give you some information about how today's session will go. All participants will be muted and will remain on mute until further instructed. We would like for you to use the question and answer section to actually ask questions. That way we can actually give you answers if we run out of time. We also will be reading some of your questions at the end during the discussion period. We would like for you to type any comments you have in the chat box. And then also we would like for you to know that this meeting is being recorded. Please do provide your name, your organization, and your geographical location in the chat box. That way we can know who is on the line and where you are located. While you're doing that, I will introduce myself. So I am Tometta Cozart, and I serve as the Multicultural Outreach and Health Equity Director for the Epilepsy Foundation. I will apologize in advance because I do know that there is a delay in my video. So listen to my voice instead of paying attention to my video so you don't get distracted. So just a little bit more about myself while we're getting some more information about who is on the line. I am certified in public health and health education and government meeting planning. I have been the former Deputy Press Secretary with the Florida Department of Health and also served as the Public Relations Manager for the Office of Minority Health in Florida. And I completed my Health Policy Fellowship with the Ohio Commission on Minority Health. I have taught college classes at Bethune-Cookman University and also the University of Alabama. And I earned my MPH from Florida's first school of public health, the University of South Florida. I am also a member of the American Public Health Association, and I serve as a governing counselor for the Community Health Planning and Policy Development section. I am also on the APHA's Committee of Health Equity, and I'm a former board member for the Black Caucus of Health Workers. So that's a little bit about me. Let me tell you more about the Epilepsy Foundation. So our mission is to lead the fight to overcome the challenges of those who are living with epilepsy and to accelerate therapies, to stop seizures, to find cures, and to save lives. I also would like to acknowledge that a portion of this particular activity is supported by the Centers for Disease Control and Prevention, and that the content that you do see today is not endorsed by the CDC or HHS or the US government in any way, and it is representative of the authors that you hear of this particular activity. So today's session is a part of National Public Health Week, and specifically for today, because today's theme is advancing racial equity. And so the Foundation's Multicultural Outreach Program is hosting this webinar to ensure that we're raising awareness of how racial injustices impact individuals who are living with epilepsy. And then we also want to discuss systematic changes that are being made to address some of these disparities. Continuing education contact hours are being offered as a part of this particular activity. So if you are seeking those continuing education units, we are offering 1.5 under the category 1 of those continuing contact hours. And so we are a provider of CHES credits. You will need to stay to the end of the webinar, and you will need to complete the evaluation link to be able to receive those particular credits. So the objectives for today are as follows. We will describe racial epilepsy disparities. We also will discuss systematic and organizational cultural changes that have been made to address these disparities. We're going to examine resources in terms of their reallocation and adaptation to address those disparities related to culture and language. And then we also will explore health equity and advocacy practices that address racial epilepsy disparities from a patient, parent, and provider perspective. So to start off, what is a seizure? So a seizure is actually symptoms of disturbance in the brain. It's a sudden surge of abnormal electronic discharges in the brain. And so these can be symptoms of many medical problems, including strokes and brain injuries. So epilepsies are the aspect of having two or more unprovoked seizures, or having one seizure with the risk of reoccurrent seizures, having an actual diagnosis of an epilepsy syndrome, and tendencies of unprovoked reoccurring seizures that are not caused by any medical condition. So you can have a seizure and not have epilepsy. So who has epilepsy? 65 million people in the world actually have epilepsy, and 3.4 million people in the US are living with epilepsy. So that's 1 in 26 people in the United States will be diagnosed with epilepsy during their lifetime. The older we get, that increases our likelihood of actually developing epilepsy. Nearly 500,000 youth have epilepsy, and more than 1 million older adults are living with epilepsies. So epilepsy disparities do exist. We did learn in 2014 from the CDC that there has been or was an increase of African Americans or Blacks who are non-Hispanic and males who had a higher rate of death related to epilepsy when compared to females and to compare to whites. And so this was one of the first studies that helped us to be able to know that we needed to actually have more intentional programming towards groups who were dying prematurely of epilepsy. We also know that there is some intersectionality when it comes to the aspect of race and having an epilepsy diagnosis. In terms of the aspect of the 3.4 million individuals that I talked about who are living in America with epilepsy, 40% of them, or over 40% of them, are coming from racial and ethnic communities, specifically African Americans and Hispanics. And then we do know that epilepsy does not discriminate. So if you have a brain, then you are at risk of having a seizure, and you could be diagnosed with epilepsy. In addition to that, though, we know that more than 500,000 Blacks, non-Hispanics, are living with epilepsy, that 3 out of 200 Asian Americans have epilepsy, that approximately more than 700,000 Hispanics are living with epilepsy. And though we do have limited data, we know that there are more than 51,000 American Indians and Alaskan Natives who have active epilepsy. And while epilepsy does not discriminate, people of color living with epilepsy do have increased health burdens. And so African Americans are more likely to be diagnosed with epilepsy over their lifetime. And of course, that's due to a variety of factors, such as head injuries and strokes. But they're also more likely to be diagnosed in epilepsy in an emergency room as compared to whites. And they're at an increased risk for sudden unexplained death from epilepsy. And so many people who are living with epilepsy, they do have a lot of health challenges, but individuals who are coming from racial and ethnic populations, they do have poorer health outcomes. And that's due to having lack of access to appropriate and specialty care, comorbidities such as mental health concerns, and then fear, misconception around epilepsies, stigma, and discrimination. This is all even more compounded if your diagnosis is with a rare epilepsy. And so we're going to hear about all of those different areas later today. And so from the aspect of the multicultural outreach program, we work really hard to ensure that we are focusing on ensuring that we are striving for equity and not equality. And so I'm sure many of you have seen this image before from the Robert Wood Johnson Foundation, where equality is giving everyone the same thing. It's not taking into consideration their actual individual needs, what's going to be the best thing for them in terms of taking into consideration their gender, their race, their ethnicity, their socioeconomic status, also their sexual orientation. But equity means that you're meeting people where they are, you're looking at those differences, and sometimes there also has to be a reallocation of resources to ensure that the people who really need certain things are getting them. So some of the strategies that we have employed over the last couple of years with the Epilepsy Foundation to try to make some of those changes has been the aspect of using racial and ethnic heritage months as windows of opportunity for us to be able to get more information out around epilepsy and seizure first aid specifically. Such as Black History Month, we use this to be able to raise awareness of epilepsy disparities and then to also give opportunities for individuals from those particular communities to be able to be a part of our training opportunities. We've also increased our partnerships with the national partners that have health equity missions, and we've asked them to serve on our boards, to become part of our training programs, to actually get their staff and members trained as well. And then we engage diverse individuals who are living with epilepsy to share their own stories and to help us to be able to identify areas of improvement. And you will hear some of that later today. So one of our other strategies in terms of being able to ensure that we're focused on race intentionally is to ensure that we have created culturally appropriate collaborations with ethnic media so that we can make campaigns that speak to different audiences that are authentic, that are in language, and that are representative of those particular populations. By working with Essence, Korea Times, Cherokee Phoenix, the Hispanic Communication Network, we've been able to have a variety of campaigns that have been educational, factual, and also have featured people who have been able to share their story and their journey. So I hope that that has been a great introduction to the aspect of some of the things that we have been doing at the national level. Now we're going to have 5 speakers give us more information about what is going on organizationally and at the ground level. So our first speaker is Aisha Akhtar, and she is the Director of Education at Epilepsy Foundation of Greater Chicago. She oversees the public-facing education effort for the 44 counties that they serve in Illinois. And she has co-authored their Seizure Smart School Act, which became effective in Illinois in July 2020. This act makes seizure first aid training mandatory in all public schools of Illinois, and she produces an annual consumer conference of about 300 people who bring the latest information of medical treatment and advances in epilepsy medication to her clientele. And I will turn it over to Aisha.
Thank you, Tameta. Thank you, everyone. Good afternoon. So my name is Aisha Akhtar, and we are an affiliate of Epilepsy Foundation. So we're located in downtown Chicago, and we service 44 counties, starting from the city of Chicago, kind of down into central Illinois. So I'm excited to just share with you some of the exciting things that we've done in this space. But I always like to start with shared definitions. And I know you just heard Tameta talk a little bit about the epileptic disease burden, but for anyone who just joined in, some of the things that I just wanted to highlight again. 1 in 10 people, as you know, can have a single seizure at any point in their lifetime. And I think that this viewpoint of epilepsy through a public health lens allows us to have a very different conversation, and it allows us to really get deeper into the brain. As you heard, there are several underlying causes that are mostly not even known. There is no cure at this time for epilepsy, and really not a lot is known in terms of causes, but we do know that genetics, TBI, these are common causes of seizures. Another thing you need to know is that 70% of people do get very good seizure control with medication. And that's great. But then there's 30% of people who really don't have good control of seizures, and then they have to open themselves up to alternative treatments. We're not going to talk about those today, but just something to keep in the back of your mind. And another thing I wanted to share is the treatment gap. This exists not only in developing countries, but even in the United States, and even in my state of Illinois, there is a treatment gap, and we will discuss that in a couple of slides. Some more key definitions. Of course, it's National Public Health Week, and a lot of you are coming from different walks of life, but just to have shared definitions here, we do talk about the social determinants of health. And these are the things that really shape our daily lives, like how we go into work. Do we have stress? What is our education level? What is our citizenship status? What is our structural condition that we live in? What's our community like? These are the things that shape us. And then we also talk about health equity. If you remember Tometta's great slide, the bicycles, health equity talks about fairness and how does everyone have equal and fair access to the same opportunity to be as healthy as possible. And so from there, we can talk about health inequities. And these are those systemic disparities in the distribution of resources. And as Tometta mentioned, sometimes they have to be redistributed. And then finally, we're going to be talking about health disparities. And these are all the differences. So even epilepsy being on a spectrum, there are lots of disparities in the way that the disease state looks from one end to the next end. So this is a concept that my grad school professors would always talk about in public health. It's this iron triangle of healthcare. We have these three concepts that are just gelled together all the time. And you need a base in the triangle. So either it's cost and access, cost and quality, access and quality, but you have these three concepts that are constantly tugging at the core of healthcare. So we're going to talk about this. Actually, the next slide, please. Adding the layer of epilepsy. So keeping the cost, access, and quality in mind, what does this look like for people living with epilepsy? And again, I'm going to focus on what we do at EF in Greater Chicago. So in Illinois, we have 15 level 3 and 4 epilepsy centers. So these are places where people can get very good high-level quality of care. I wish I could tell you that these are all geographically located throughout the state, but they're not. In fact, you could probably walk to 5 of them from downtown Chicago, and then the rest are kind of sprinkled throughout the top half of the state, and then south of Springfield, there really isn't anything. So they're not geographically spread out. And an epileptologist, by the way, is a neurologist who has an additional training in epilepsy. So a lot of times people kind of just stop there. They just go see the neurologist and they don't get that extra level of care, hence a treatment gap. And that kind of goes into the quality. So the depth of their care is also going to depend on what level of training their provider is. So if they're going to see someone at a level 3, a level 4 center, they're going to have advanced quality. But if they're only seeing a neurologist and they have a difficult to treat epilepsy, there's going to be that gap of treatment. And finally, cost. So epilepsy is a very expensive chronic disease. And it doesn't just stop there. A lot of people, I would say 80 to 90% of people who have epilepsy also have some degree of mild to moderate depression or anxiety. So there are other comorbidities that are kind of layered in to epilepsy as well, contributing to the increasing cost of epilepsy. Okay, I know there's a lot of words on the screen, but now we're going to talk about health inequities. So these are, again, things that we have seen at EF Greater Chicago and things that have worked for us. So speaking of like the health inequity of location. So again, we are centrally located to the city, and most of our clients who come to see us come on public transportation. We are centrally located. It's easy, it's cost effective, or they might take rideshare or paratransit. And that's, depending on when they get picked up and when they get dropped off, they're at the mercy of the driver. One of the silver linings of the pandemic, if I could say there is one, is that we now have equal access for everyone to access services. However, there's a qualifier with that, is that it's everyone who has a smartphone. So now we have a different equity issue. But at least we were able to feel that everyone was able to have the same access to their, whether it's their provider or coming to meet with a case manager in our office. So now they were able to do that virtually. Another situation that we were dealing with was the knowledge gap. And Tometta kind of referenced this earlier, that it's really important to speak in the language of your community. So we were able to translate posters in 7 other languages. We have Spanish, French, Polish, Arabic, Hindi, Urdu, and I'm probably forgetting one. And so it's really exciting to be able to go into a community and share this information and have a community feel represented. And then we have another inequity of the treatment gap that I was referring to. So again, the whole state of Illinois doesn't necessarily have access to all of the epileptologists that we have in the city. for example, we work with so many centers in the city of Chicago, but the southern part of the state does not have this access. And so what you're seeing there is that lack of complete care, the lack of wraparound care. So what we've done at EF Greater Chicago is we focus ourselves as the bridge in between our communities and our clinics. And we've been able to help to have our physicians include us in their after summary reports, their EMRs, as part of a continuity of care. So they leave their doctor's offices and then they reach out to us for additional case management, clinical services. Again, everything we provide is free. So we are able to address the treatment gap in that regard. All right, so now again, this is today's theme, addressing racial and ethnic disparities. It's not an unknown fact that epilepsy affects people from the Black and Brown communities unfairly. And so these are sort of the disparities that we are seeing. And one thing I think we need to do is start to view racial equity as a desired health outcome instead of a means to an end. So when we put that as an outcome, it allows us to get there a lot faster and in a more equitable way. And one way to do that is to look at intersectionalities, as Tonya also mentioned earlier. So for example, are there differences in health outcomes of, let's say, an English-speaking Hispanic woman versus a non-English-speaking Hispanic woman? And I think it's time that we start looking at all of these different disparities to see where the gaps are so we can address individual needs. So that's something that we've done. So we actually have people on staff that speak Spanish. We have multiple different languages that we can speak. And we are able to put ourselves in these different demographic groups. We have connections in the Muslim community and lots of churches that we work with. And we want to make sure that we represent our client base. And the one thing I wanted to point out here is that when there's the lack of health equity, we're basically enabling that sort of structural racism that we're trying to avoid, which then becomes a risk factor and then leads to poor health outcomes. So that's something we have to think about. And so here we are. So now we have to create these culturally sensitive solutions that look like our community. It is unfair to walk into a community and create a gap analysis without even getting the buy-in from the community. So we have to establish trust. So we need to do collaborative needs assessments to find out what does the community need and how can we help the community to get there. We also have to address health literacy. So that's going to be different. Even I can see it in the north side of Chicago compared to the south side of Chicago, to the suburbs, to the central part of the state and to the south. We have to make sure that we're providing health information at the level of our people, speaking in their language. For example, in the Chicago public schools, I've been in school, there are some schools that have like 37 different languages, which is incredible. And I don't have 37 different posters, but there are schools that are completely either Arab speaking, Spanish speaking. And so we're able to work with them and provide them the needs for their communities. Most important, and this is my last statement here, is to make sure that your organization looks like the people that you serve. So from the inside, if your organization doesn't reflect the outside, it will crumble. So it's very important that we start with a strong foundation and make sure that we address the health inequities from the inside. This is a quote that I just love. You can read it. Race is not the cause of inequity. Blackness is not the risk factor. Racism is the risk factor. And again, if we view this as a positive health outcome, I think we can get there a lot faster. Thank you.
Thank you so much. I now have the pleasure of introducing Mr. Glen Lloyd. He is the Executive Director and the CEO of the Epilepsy Foundation of Minnesota, and he's had that role since March of 2020. He is a passionate advocate for all people with epilepsies and seizure disorders. He has more than a decade of experience in development and program management. He has been doing that at the higher education level, also in social services. He also served on the board of the Epilepsy Foundation of Minnesota for 2 years before becoming its leader. He's also served on President's Councils of Diversity and Inclusion and Equity committees at various locations, including Gustavus Adolphus, and he has a bachelor's in arts and communications, as well as him being a native of Washington, D.C. So with that, I'm going to turn it over to Mr. Lloyd.
And thank you, Tonya. Thanks for the invitation and welcome to everybody to this really important discussion on advancing racial equity and epilepsy. So I'm gonna be your practical approach. While I would love to sit down with each and every one of you and have a one-to-one conversation around the work that I've done, I wanted to take you through the 3 segments as outlined on the screen, right? What did I do, how I did it, and what I'm doing to advance racial equity in epilepsy in hopes that it encourages you to continue in your journey. Next slide, please. So where do we start? What did I do? Tip 1. Well, first of all, I would encourage you to be yourself as I did for myself. If you don't know yourself in relationship to others, population groups, it's time to learn yourself. And I think that that's a really important lesson is to learn yourself. Be committed to knowing how you are in comparison to others, not as to compare, but as to find alignment in the journey. Next slide, please. So what does that look like? Well, for me, it started way back when I was a young boy growing up in the District of Columbia's region in a great Black community that encouraged me to remember, I too sing America. I am the darker brother, right? The ownership that Langston Hughes was encouraging in Black folk is the same thing I'll encourage in you, is that you are the American story. And so it becomes really important that as you own identities, you start to transition and find yourself wondering what part of America, and in my case, Minnesota, in Eastern North Dakota, am I responsible to listen and know what's happening? Next slide, please. So what does that look like? For me, it's embedded in all professional development and studies. So the statement is, I'm my identity that I'm highlighting, and then therefore I use some sociological approaches to thinking about my relationship to community. So I'm Black. So it's really important that as I've had professional development in this area around equity and inclusion, that I've come to learn around a critical race lens. This work could be found in people's work like Joy DeGruy, as well as Shakti Butler, Dr. Eddie Moore Jr. These are some of the luminaries that helped me during my journey discover that while being Black is really important, it's also important that I carry a lens to the world. And when I talk about lens, it's your very being, it's your approaches, it's all your senses. And so while I find myself as being a part of the marginalized group of being Black, I encourage you, if you're in that group or in some other population group based around race, is to start to learn the approaches and the understandings that can unlock your approach in achieving racial equity. Secondly, right, my identity is wrapped up in being male and a millennial and heterosexual. Well, the work of Kimberly Crenshaw becomes really important if you're going to understand intersectionality. It becomes a motivating factor to how to approach one another and see the nuances in our identity that we start to get to the base level understanding. Think of it as the common denominator and driving down as far as you can. If you want to aim for equity, find those who are most disadvantaged in the community as a way to build back up, and use your identity as a way to explore, to learn more about where you are advantaged and where you may be marginalized or underestimated, under-resourced. In the old days, we would have said just segregated. These are all adjectives on how that comes together. Another piece of my identity that becomes really important in how I've done the work is I'm from the DMV, right? So the DMV is known as a community that is, the world comes and converges on just as much as New York City has that same brand. So what did I have to do? I had to put on a multi-ethnic lens, right? So how do we find spaces for justice and conversations around equity? Well, it is to be in community, know those who live around you and are most closely associated with you. That becomes really important. The other thing that I'll say is, and as you think about this work of identity, and me talking about my identity, is that I'm Christian. I identify as a Christian, and that's important because I've gone through professional development in establishing an interfaith lens, right? So Ibu Patel out of Chicago, I went to the Institute. It was really important to my formation to come to appreciate the journey of justice and the interfaith opportunity I have to lock arms with different faiths or of no faiths and everywhere in between as a way to move forward. Now, once again, the tip started out, what did I do? Well, I took every opportunity to learn more about myself, and I've taken my center as a way to move forward. Next slide, please. So then we talk about the journey of how did I do it? What's the tip? Well, it's pretty simple. It's be curious, right? And so in that first statement of be curious, I'll tell you one of the best professional development lenses I've ever adopted was from a former colleague who said the people that she'd like to work with that have one important trait. They are interesting and interested. Being interested provides you an avenue to growing your appetite and your willingness to fight for equity. So for me, I came from higher education. That was my first love. It still is a love. I've come into this organization, into patient advocacy, particularly focused on epilepsy. And I've committed that same type of curiosity that I had about what makes higher education tick and successful. I've thought the same about people with epilepsy as well as the chronic condition itself, right? So those are two separate issues that I'll point out in how I did it. Is that I first made an observation that there's a lot of research about the chronic condition, epilepsy. And then secondly, there is an aspect to this disease that is all about the people. Next slide, please. So what did I do? I went back to being curious, right? Like back in the good old days, right? We all had the World Book Encyclopedia at the library or at home. That's how you scratch the itch of curiosity, was going and reading. The same can be true about a Google search. I will tell you, one of the important mantras in my life is when I don't know something, the first answer is use Google, right? And then build off of there. Well, what it brought me to is in the space of epilepsy and people with epilepsy, there's a lot of highly respected research happening all over the country. And these are the places that I would encourage you to centralize your approach when thinking about epilepsy. Tometa did a great job of giving an overview about what we know about people with epilepsy, particularly through a racial and ethnic lens. That became the framework to my approach in understanding one, epilepsy, and secondly, the public health aspects of people with epilepsy. The one that I think is kind of understated here, and it may seem like I'm self-serving here, so I'm not going to make any apologies about it. But while there are some well-known federal agencies here leveraged, I'd really encourage you to look at the National Epilepsy Foundation in this space of health equity. Lean on resources like Tometa. You become well-equipped to start to learn what is the regional approaches to people with epilepsy, and then that may inform your populations that maybe aren't as large as yours, but still show up in your community. Remember, all means all, right? My commitment as a CEO, executive director, is to encourage my team to serve all. All right, next slide, please. So the third and final piece is, what am I doing? What's the tip? Okay, so this is gonna seem hokey and you say, Glenn, this can't be true. I promise you, if you call any one of my staff, they will tell you the number one aspect to how I think about our work is I am optimistic. In my quiet moments, in the awkward moments around conversations of equity and inclusion, I am always optimistic, right? And here's why. There are painful moments in getting to the commitment around equity and justice and inclusion, but it's based in a history of human struggle and triumph, right? And that's really important. It is the struggle and the triumph that becomes really necessary for setting some motivation within you, right? So I come from an African-American enslaved history and legacy. And so it is literally, it feels like a part of my DNA to know struggle and triumph. And that sets the standard for my approach. So my optimism is based around the fact that we've come a lot further than where we were. And I can see on the other side what's possible when I put myself at the center of doing something about it. So that's the other aspect to this tip is, Set a standard for yourself. How are you growing your worldview, your lenses, your professional development? One of the things that I often did is I would go to a conference and I would immediately go to the session that I knew nothing about, because I had a sense that it would pay off in the long run in moving me forward. I'm going to ask the same of you. Make the individual commitment in your standard to be in a daily, weekly, yearly process of being curious, being optimistic, and learning more, and then collectively hold each other to that standard. Next slide, please. I think it's really important that Bell Hooks really frames out this statement, right? That these days, I wonder more and more why people are pessimistic when American history actually supports optimism. That's an important message you need to hear right now, right? Everything we're talking about is people with epilepsy within America. And it seems like structurally, we are going through some really important aspects in time that, like, oh, I shouldn't be optimistic. And Bell Hooks, and I totally agree, says, actually, this is the time to be optimistic. Just look to where we've come from. Next slide, please. I want to then center back on this point of a standard because it becomes really important as a CEO and thinking about the work that I do on a regular basis. Everything you see listed on this page is what we're working on right now. Everything from our fiduciary board's investment with a community committee that has all the power and influence to shape our vision, to hold us accountable, to move us ahead, to think about the reallocation of resources. We have it happening at that level. We don't talk about DEI out to the community. It's a commitment to ourselves and our ability to serve all. So what does our team do? I really want to encourage you. If you've never done a 21-day challenge, you should Google right now. And I think it was dropped in the chat, Dr. Eddie Moore Jr. He has designed a 21-day challenge of how to beef up, how to strengthen, how to improve your muscle, your very being of thinking about diversity, equity, and inclusion. We've now done 3 challenges in the aftermath of George Floyd's murder, because when you're at the epicenter of things changing, you better catch on to the movement. We've done that, and this is one of the ways we've moved forward. Community outreach and interpersonal dialogues. I think Tameta pointed to that my bio said that I have a degree in communications. It's about the one-to-one willingness to pick up the phone. Where do you start? You start with who you know. Everybody knows someone who can improve your worldview. Get to the business of using your LinkedIn, your Facebook, your Insta, your email to pick up the phone and say, I'd like to learn more. Can we have a cup of coffee? Starting with coffee, tea, water, or a happy hour will always improve your chances of getting a meeting. Do it. Community conversations, listening, interested in what your community has to say about their own interest in well-being and wellness and how they've gone about pursuing that, as well as to gain exposure around epilepsy becomes really critically important. And finally, budget prioritization. Don't tell me you're doing this work until it's showing up in every part of your organization. Aisha appropriately pointed to the fact that when you're delivering programs and services, you should be culturally relevant. I'd also think about the engagement, the reciprocity in any good partnership. If you are extending resources and information, extend the other hand and say, I'd like to see you a part of our engagement and our philanthropy, where people feel empowered to go and tell your message, the better your message becomes. So if you have your seizure first aid in 7 languages, show me how your invitation to your gala and your walks is also in 7 languages. Nothing gives people more dignity and respect than to give them every opportunity that English-speaking, white, non-Hispanic folk, particularly men, have been given. Then we know that we're trying to achieve the same goals. Hey, listen, that's what I did. That's how I did it. That's what I'm doing. If you ever want to have that one-to-one conversation, please know that I welcome it. Thanks so much. Oh, good point. I got one more slide. I shouldn't leave you just too quickly. I want to encourage you to the Wesley rule. Do all the good you can by all the means you can, in all the ways you can, in all the places you can, at all the times you can, to all the people you can, as long as ever you can. That's my encouragement to you. Be in the business of using all of the time you have to make our communities better and to strive for equity. That's what I've done in my work. I hope it's encouraged you.
Thank you so much, Glenn. You continue to encourage us. And now we're going to hear from Tonya Nash. She's a public health consultant in the Metro Atlanta area with over 15 years of experience in public and private sectors. She's certified in public health education, and she has a certificate in digital health communications from Tufts University. Tonya is the president of Spectrum Public Health Strategies, LLC, and the founder of the award-winning Autism Faith Network, Incorporated, a nonprofit which recruits and empowers faith-based communities to serve people with epilepsy and their families. Tonya is the mother of 2 autistic sons, one of which has been diagnosed with Lennox-Gastaut syndrome, which is a rare form of epilepsy. She is passionate about advocating for underserved communities and communicating health information in a way that people from all backgrounds can understand. Tonya?
All right. I want to first start off by thanking Tamina Cozart for inviting me to be a part of this distinguished panel. I am happy to share my experience with you to help inform your future work in public health and epilepsy. Next slide. And the one after that. All right, so what I'm going to do today is I'm going to talk to you about our family's personal journey, the diagnosis, treatment, and advocacy opportunities for public health professionals. And I just have one slide. So we're going to do this all in one slide. My husband, Jamie, and I have 2 amazing sons, Daniel, who is 13 years old, and Nicholas, who you see pictured there. He is 8 years old. I am very familiar with being a part of a special needs family because I have 2 sons who have been diagnosed with autism. And, 2020 was a difficult year for everyone. COVID-19 came on the scene and things changed forever in our family's life on August 18th, 2020. So back then, we are in full into the pandemic, and it's time for school to start back up all over the United States and especially in the South. And we were on our 3rd day of online learning. And it was an adjustment for us because, we had 2 sons that were doing virtual learning, and my husband and I, we were both working from home. So we had 4 people, all streaming internet, trying to get things done. And I'm sure many of you relate to that. And around 10 a.m. on that day, my son, Nikki, I was helping him with a worksheet that he had to do for class. And he wasn't focusing as well as I thought he should have. And he slumped down his head, he dropped his head down. And I thought to myself, is he going to sleep? And so I lifted his head up. And when I lifted his head up, I noticed that he was having a seizure. So I called 911. And it was the most scariest day probably of my life. The EMTs came, and because of COVID, only one parent could go with him to the ER. So I went with him, and during the time that he was in the ER, he had a CAT scan done. They checked his blood glucose levels, and in a few hours, he started to come around. But there were some things that I noticed about his care while I was there. When he started coming around, the hospital staff was asking him about his pain levels. And as I mentioned before, my son has autism. And so he can communicate, he's verbal, but it's difficult for him sometimes to communicate with unfamiliar people, and especially during times of stress. And so he was unable to tell them about his pain levels. So I asked him if they had pictures or any kind of photos where he could indicate his pain levels based upon the pictures. And they didn't have that. And it really surprised me that something so small was unavailable. Where you receive care matters. So another thing I noticed during our time, as I went back and reflected about our visit to the ER, was that the EMTs that came to our home, the physician assistant, the ER doc, the radiology tech, the assistants that helped, the person that pushed him around in a wheelchair to get from place to place, all of them were white. There was no one working there that looked like us. And I thought, how strange is that in an area so diverse as Metro Atlanta that no one looked like us? So when the ER doctor came in, he pretty much said, well, I don't think that your son will have another seizure. The CAT scan came back great. But he will need to see a neurologist before he comes back to school because I'm concerned that the virtual learning may have triggered his seizure. And so I thought, oh, okay, well, no big problem. We'll go and see a neurologist. It shouldn't be an issue. Wrong. I, I went home and tried to call and get him an appointment to see a neurologist. And so many were saying, oh, there's a waiting list. One even said, oh, it'll be 3 months before he could be seen. And I'm thinking to myself, there is no way this can happen. So I did some extensive research and found a neurologist that was about an hour and 15 minutes away from our home in good traffic. But at that point, I was desperate. So I called the office and they too had a waiting list, but I explained to them our family situation and they decided to see my son within a week. So that was a blessing. When they saw my son, the neurologist was able to get an EEG done right away. And almost immediately after reviewing the EEG, our neurologist, who was a Black woman, by the way, was able to diagnose our son with Lennox-Gastaut syndrome, which is a rare form of epilepsy that is known to be hard to treat. So the next bullet, treatment. Since my son was diagnosed with Lennox-Gastaut syndrome, the neurology office has been like family to us. They have helped us with many insurance issues, medication side effects, and applications for medical homebound from school. And one thing that I love about the neurologist that we have is that she doesn't just talk to us about the diagnosis that my son has, but she also talks to us about cultural issues that we need to be aware of that come along with that diagnosis. For example, my son had a 48-hour EEG that was done, and she called me to give me the results of the testing. And she told me that my son had frontal lobe seizures, which can cause someone to be aggressive and have impulsive behavior. And because my son is an African-American male, that is something that I really need to be cognizant of, especially during the climate that we're in right now. And so I was really thankful that she was willing to address these cultural issues with me. And I realized after the conversation that many healthcare providers probably would have never even thought to consider the fact that epilepsy and the form of epilepsy that my son had could be a concern with him being an African-American young male. So the next part, advocacy. So right now, we know that there is a stigma with epilepsy. And as the mom of 2 sons with autism, I'm very aware of how stigma can keep people from seeking a diagnosis and getting the care that they need. And it's very important that we as public health professionals speak up about epilepsy and the impact that it has on our society. And like Aisha had mentioned earlier, there are many social determinants of health that come into play when we're talking about epilepsy. And so I'm going to talk to you about a few of those things and then talk about some ways that we as public health professionals can flex our advocacy muscles. And one of them is dealing with access to education. Epilepsy can greatly impact the quality of a child's education, especially if their epilepsy is not under control. My son's seizures greatly increased around Thanksgiving, and we were having some difficulty with controlling them, which is standard for Lennox-Gastaut syndrome. And so in January, I applied for my son to be considered medically homebound from school. Now, I work from home and I'm able to balance it, but what about families that have to work outside of the home? What resources are available for them? Then we have access to healthcare services. So like mentioned before, African Americans and Hispanics are more likely to receive care for epilepsy in the ER, and they're more likely to not get medication that can help control their seizures, and also less likely to receive specialized care. And you have to consider economics because healthcare can be expensive. And so the economics that go along with that, like the cost of medications, the copays for every visit. And when you see a neurologist, that's a specialty care. So that's more money than your regular doctor. And the EEGs that you have, that's a cost. Protective equipment, like my son wears a helmet, you got to pay for that. And so there's so many extra financial expenses that come along with that. And that's something that we have to be aware of. Then we have transportation. So like I mentioned before, my son's pediatric neurologist is an hour and 15 minutes away with good traffic, but it can take as much as 2 hours to get there. And there's not a lot of pediatric neurologists in this area for the need that we have. What if, I was a parent that didn't have reliable transportation or didn't have gas money to commute 70 miles one way and then come back? What if I needed an office that was on the bus line? These are all things that we need to consider. Then also language and literacy, which is also mentioned earlier. Epilepsy can be a very complicated thing to understand. I have a master's degree in public health. I'm a certified health education specialist. I have training in health communication, and I still had to do some additional research to understand some things about my son's diagnosis. And so what we have to do is we have to make sure that we're breaking down health information in a way that people from all backgrounds can understand. It is no good to the people that we're trying to help if we're talking to them about a health condition and they don't understand a word that we've just said. In addition to that, when we're talking about language barriers, it's important to have information translated to them correctly, but then we also have to make sure that that translation takes into consideration cultural issues. And then with all of those social determinants of health, COVID has exacerbated them even more. So as public health professionals, what can we do to effectively advocate for those with epilepsy and their families? Well, one thing I would recommend is to get trained. The Epilepsy Foundation has the seizure recognition and first aid training, and it's free. And in the last, it lasts for 2 years. And for my fellow certified health education specialists, you can get continuing education credits for taking this training. You never know when you may run into a situation where someone is having a seizure near you and you may need to help, and you want to be able to help the right way and not rely on old knowledge like putting spoons in person's mouths whenever it's time for when they're having a seizure. Also, get active. Include information about epilepsy in your programs and share information about epilepsy in your network. And lastly, get involved with legislation. There is a need for new therapies, research, and affordable medications for those with epilepsy, especially those with rare forms. And we need legislation that also supports caregivers, because having a family member with epilepsy can affect a person's ability to work a typical 9-to-5 job. So thank you very much, and I look forward to your questions at the end.
Thank you so much, Tonya. Next, we're going to move to Dr. Kimya Nuru Dennis. She is an activist, sociologist, and criminologist. She also is an educator, an evaluator, and a researcher. As founder and owner of 365 Diversity, Dr. Dennis provides results-based services for decision makers in K-12 schools, colleges and universities, businesses, and nonprofit organizations. She emphasizes in practice, she puts an emphasis on identities and experiences that shape every aspect of people's lives and how they're being treated, focusing specifically on a range of demographics, cultures, and social determinants. Having a brain condition and epilepsy motivates Dr. Dennis to increase cultural awareness and cultural inclusion in local and national epilepsy organizations, in neurology and neuroscience academic programs, but also in training, research, policies, and procedures. Dr. Dennis taught health equity for medical and health undergraduate students, graduate students, and medical residencies, including art-based classes for neurology graduate students. Born and raised in Richmond, Virginia, Dr. Dennis lived in North Carolina for 17 years, attaining her doctorate and teaching a college in Winston-Salem. She currently lives in Baltimore, Maryland. And with that, I'll turn it over to Dr. Dennis.
Thank you so much for having me. And I appreciate this discussion. I really do appreciate these open dialogues about epilepsy, and particularly epilepsy for people with oftentimes underserved racial and ethnic identities. And so just some background about me. Since 2014, I've been living with a diagnosed brain condition, birth disorder in brain, and epilepsy. And one of the many issues was I lived in Winston-Salem. I was full-time faculty in Winston-Salem, and it was difficult to find good neurologists and good neuroscientists. So good does not mean that you've memorized the stuff from graduate school and you can repeat it to a patient. Good means that you actually can look people face to face, eye to eye, and explain it using everyday language. So that's one of the issues, because even prior to my being diagnosed with epilepsy, I was doing work with health organizations to address that. And it was wonderful because eventually I did find some good neurologists. I never found a good neuroscientist, and that's one of the issues with neuroscience professionals. But the good neurologists were people who actually could have those conversations beyond just repeating terminology and words in a very condescending tone. So that's why I specialize in addressing what it means to actually help people beyond the paperwork. And if people are suffering, not just put them in the numbers. And I want to highlight this before I talk about my background, because one issue that persists is also being illustrated in COVID vaccine. So many people, including medical and health professionals, are telling people, in fact, almost yelling at people about taking the vaccine, despite the fact that the COVID vaccine has not been tested on every health condition, including certain brain conditions, including epilepsy, okay? So this is important because especially if we're talking about the disproportionate harm on African Black people, Indigenous people, non-white Hispanic, non-white Latinx, Latina, Latino, and Asians. I want you all to think critically about what that means and how COVID vaccine language illustrates centuries of how underserved people have been told to just deal with it. That if something negatively harms us and we might end up dying from it because it was not a tested outcome, then instead of changes happening to medical and health facilities to say, oh snap, maybe we shouldn't. Instead, we just end up a number in a data crunch for someone's peer-reviewed journal article that gets published and goes in your CV and you get tenure or whatever, okay? So I want you all to think about this for COVID vaccine. So that's why my work is very unapologetic activism. It sometimes offends people, including medical and health students and medical and health professionals, because our lives mattering is not just about yelling at police officers. It's also about sometimes yelling at medical and health professionals who they do this work and sometimes they are contributing to our abuses and our deaths, okay? So saving our lives does not require smiles. It does not require what people call professionalism, because professionalism is 100% based on white people. It's based on what men consider professional. It's ableist. It's rooted in 529 years of what white people have done on Western Hemisphere. So I tell people, if you only can handle professionalism at the cost of our health and our lives, then you definitely are not a community health advocate. You are somebody who has memorized textbooks. you've memorized journal articles, you've memorized the DSM, you got a good job, you're gonna get through school, but you are someone who should not be claiming that you really are public health interested and interested in helping communities and patients. And I will end with that request in a little bit as well in terms of community patient advocacy. So my background with my having epilepsy also furthered my demand for people to stop saying strong Black woman. After all these years as a sociologist and criminologist, when I started struggling with epilepsy, having seizures, guess what? I was still teaching the courses. I was still operating the academic program that I created and coordinated. I was still doing community work, doing presentations. I was still on board of directors, doing all of that. Like I didn't just get out the hospital from a seizure, okay? I was doing all that, and doing all that actually furthers the harms to Black women. So from then on, since 2014, I started saying, Black women were not stronger. We can't say strong Black woman and then act baffled when the medical and health professionals think that we have a high pain threshold. And when I say medical and health professionals, yes, this is white dominant. Okay, so like when I've been on these mental health board of directors, these suicide prevention board of directors, it's white dominant, yes. But there's plenty of Black and brown folk who contribute to that white supremacy, okay? They contribute to it. They use needing to finish their academic program as an excuse. They use needing to pay their bills as an excuse. I have done years of these trainings in which Black people in particular have been getting CEU credits for my trainings. And when I challenged people to do better for their own people, they've told me in my trainings that they need to pay bills, okay? So I really want people to understand the full span of what's going on when we talk about these issues, not just with epilepsy, but the overall health issues. So since 2004 is when I really started doing the community health work. And that was because I was taking a qualitative research course in the doctoral program. And I went into it bright-eyed, bushy-tailed. I was so excited. I was going to start doing qualitative suicide research, particularly Black suicide. And I went into it really excited because I really hoped that most medical and health professionals, medical doctors and nurses were in this field to help people. Okay, that's not really true. So when I do trainings, I walk into it and I say, a lot of you all are really in the wrong profession and our lives are at risk because of that. And I learned that since I started doing this work in 2004. And then I became on board of directors when I finished my doctoral program. And I just had to open my eyes and be like, oh my goodness, these board of directors, they really thought I was the good Negro. They thought they were going to add a Black woman and I was going to be in charge of the community health component, because I literally was the Black person who went into Black communities, had conversations about mental health and suicide. And that's also when I was co-chair of the Juneteenth Health Committee. So I was doing Juneteenth health every year. And one of the people who was helping vendors, health vendors, mental health vendors, and all of them to get vendor tables at Juneteenth. And it illustrated that most of these people did not know how to get from behind the vendor table to actually have conversations. They literally thought they could come to Black folks Juneteenth and say, sign up for our email list. Here's a pamphlet. I was disgusted. And some of these people included Black health professionals and Black medical students who walked around with their white coats, proud. And I had to tell them there's really nothing to be proud of, okay? Because like this is the outcome, that you're getting clout from white people, but your own people are suffering. And I'm telling you that you're not reaching your people, but all that matters is your white coat and the clout. So that's when I really, after all those years, I had to really change my approach. And changing my approach in this health work also changed my approach to my own health condition of epilepsy. Because from then on, I was like, the work that I get for myself has to match the work that I want for my people. So even if I ended up in an emergency room from a seizure, I was the neurologist's worst nightmare because they could not come to me talking about long theories, because I would wake up real quick and say, look, not only do I have epilepsy, but I also specialize in health equity. So I will file a report on you, okay? And when I say file a report, I don't trust the patient advocacy offices of hospitals. They are there for the hospital, okay? So when Black people, for example, are having epileptic seizures, having brain issues, and if they're not being properly treated, which is often the case, if they say, I need to file a complaint, guess what? Of course, they're told, yeah, we'll go get, someone to come in and help you file a complaint. This is just like going to the human resources office of an employer, right? It's 100% based on protecting the facility. So that's why one thing that I want is for communities and patients. So I often say communities and patients because we're not just patients, we actually are larger communities beyond that. So we have a lot of Black people with epilepsy who will never go to the hospital even after a seizure. They will never have a neurologist. Even if they're put on Keppra, for example, for seizures, they might never take the Keppra. And so we need a resource beyond being told to file a complaint with a health facility. Because health facilities cannot be trusted no matter how much people are quote unquote professional and they smile at us, okay? So that's why on the realities of what's going on. And this is when I do trainings for 365 Diversity and as a consultant beyond that, I tell people, I'm not here to make you feel comfortable, okay? I'm here to help people's lives. So this is why 365 Diversity developed the We Need Help training. So We Need Help trainings, I created that years ago because based on all this work, I was just noticing that so many people theoretically wanted change. They had so many ideas for change. They really just wanted to sit in trainings though. Like they would have all the CEU credits in the world. But then I say, okay, what are you really changing? Okay, you might be putting a new book in a class to have your students read. Okay, what are some real policy implications? What's really happening? And not just happening in your own space, but why should communities trust health facilities and hospitals if you all are keeping all of these supposed changes secret? It's just like when we talk about police departments. It's just like when we talk about schools. Medical and health professionals are not helping anyone but themselves if everything they're doing, supposedly, is only known within their collective. If you all are the only ones who know about it, it can't be for us. And if you all are not doing annual assessments or even 6-month assessments to see what are the outcomes of not only patients, but what's going on in communities, do people know we exist on that street corner, Bel Air Road in Baltimore? Do Black folk know we're here and are not just distracted by all those liquor stores? They can actually see the health service there. If you all are not researching that, and not just for publication, but actually because you care and want to do an assessment and make changes, then I don't trust you. And why should communities trust you? So when I say we need help, we are talking about that equity. We are, and not just catchwords. So when you go to 365 Diversity website, you'll see I'm not a fan of catchwords. Every time someone uses a catchword, I tell them, just like I told my students when I was a professor, what does that mean? Like beyond what Webster Dictionary tell you, what does that really mean in terms of measurable outcomes and practical application? So this is where I say demanding honesty, changing academic programs in undergraduate and graduate health programs, changing the course curriculum, teaching people how to actually reach people and have conversations with people, whether it's patients coming to your office or you're at a community health event. When I invite you to a community health event, I'm not inviting you to sit at your vendor table and look at your phone. And that includes the Black folks, okay? So this is not just about being a polite person though, okay? It's about what people are taught and allowed to do, and no one's stopping them from doing that. So I'm just going to reiterate that again. When I do We Need Help trainings, it does qualify for CEU credit. So there are health facilities, health professionals who will take that. But the work I do is 100% results-based. I'm not here for you to come to my trainings and sit there like this is time for you to take a nap, okay? This is the time to hold yourself and each other accountable as colleagues. Because over the years, many health professionals have told me that they just need to keep their job. And this is the disguise that's used to silence our people for centuries. For centuries, Black people in particular have been told to trust that changes are happening, especially if you put Black folks on it, right? Trust the change is happening and be quiet until there's another tragedy so we can protest down the street. And I'm just telling Black people that we actually do not have to trust medical professionals. Okay, we can demand changes and we can demand evidence because we cannot die based on this notion of trust. Thank you so much.
Thank you so much, Dr. Dennis. We now have our last panelist, Dr. Sasha Alick Lindstrom. She is an assistant professor of neurology at the University of Texas Southwestern Medical Center. She specializes in diagnosis and care of patients with epilepsy, using the latest medications and treatments to find the best options for each individual patient. Dr. Alick pursued her undergraduate studies in neurology, in neurobiology and psychology at Cornell University. She went on to earn her medical degree and completed her internship in internal medicine at UCC School of Medicine back in her home of Puerto Rico. She completed her residency in neurology at the University of Texas Health Science Center at Houston, and then she received advanced training in clinical
neurophysiology.
Thank you. Sorry. Epilepsy. Through separate fellowships at the University of Texas Health Science Center at San Antonio. She is the vice chair-elect of the Underrepresented in Neurology section at the American Academy of Neurology, which is one of the main reasons why we invited her to speak here today. And she is a part of the Professional Advisory Board for the Epilepsy Foundation of Texas. All right.
I think that was enough. I think I'll skip all my intros. So like she said, I'm Sasha Alick. I'm still getting used to the Alick Lindstrom, the hyphenated, but I'm very happy to be here and honored that I was invited. As she mentioned, I am the vice chair-elect of the URN and AAN, which I'm really, really excited about to take over, because these are all topics that are very important to me and that I see and encounter a lot in my practice. And I want to be able to address them at all levels. So for the talk today, I wanted to talk about diversity, inclusion, and equity at all levels in neurology and medicine. Although it sounds a little cliche, yes, the time is now, and meaning we finally have some momentum and buy-in from a lot of people who were not cognizant or did not want to see the reality that there's a lot of systemic racism and inequities. But with all the recent happenings with the pandemic and social events and whatnot, it's become apparent and highlighted, and more people are striving to create some change. This includes large medical and research institutions, as well as hospital systems like the one I work at. I know our department, for one, and a lot of the departments have created task forces or committees to address these issues, not only within the department, but campus-wide, because not only do we want more people who look like our patients to provide better care, we also want to ensure that everybody who is here feels included and like they have a voice and that they matter, right? It's an urgent matter because the lack of health equity, we know, leads to negative health outcomes. And sadly, this mostly happens in vulnerable populations, which we set out to help, assuming because we went to medical school, right? you can do the next slide. So I'm going to start at the level of the lowest level, I guess. We are at the level of the medical healthcare education institutions. Like I mentioned, a lot of the departments have created individual DI committees and designated representatives. I know for one, I'm the one for our Department of Neurology, and I'm in contact with a lot of the hired chairs and vice chairs for DEI initiatives, and more importantly, at the medical education level, because a lot of people go to medical school, some go for their degrees, their white coats, the prestige. A lot of us go in because we really want to help people and make a difference, right? And unfortunately, it doesn't matter what your background is or what your priorities are, you're going to be providing care for all different kinds of people, right? So you should know and be aware of diversity issues and how not everyone experiences life the same based on all the different factors that affect us in an intersectional manner. One of the first things that we've done here is provide insights into implicit bias and structural racism, inclusion. We're having some workshops on gender affirming care. I unfortunately have seen a lot of trainees and people in the hospital not want to address the fact that somebody may be non-binary or have different beliefs, and they pretty much think that they're just there to prescribe medication, take care of a medical condition, when in fact we're there to take care of the whole person, right? Especially in neurology, and even more so in epilepsy, which I'm very passionate about. Another thing is, as a diversity officer, I'm part of the recruitment committee, and for our trainees at the resident and fellow level, and involved at the medical student level, because we want to ensure that we finally break through that 2 to 4% of anybody who's BIPOC, like on campus, so we can have a more diverse healthcare force taking care of our patients. The other thing is that I am encouraging a lot of my committee to go out into the community and kind of provide information and education to minorities and people who are maybe at the elementary, high school, college level, who would never have thought to consider a career in this, to let them know what neurology is and whatnot before it's too late. Because trust me, whenever we get applicants, it's like slim pickings. You can't really, you try to weed out and see who's qualified, and you want to make it diverse, but a lot of people don't even make it there. And we want to make sure to be able to take part in that early on, so that we do have a vast, applicant pool. At the level of our national societies, our largest one being the American Academy of Neurology, the AAN level, back in 2019, September 13, they put out a guiding policy on equity, diversity, and inclusion. And this is just a snapshot from it. I just really like the part of inclusion is the act of employing systems, policies, and practices that support, engage, and demonstrate value for all individuals. Diversity of thought and the inclusion of new ideas and perspectives can help an organization to increase its creativity, generate new ideas, enhance problem solving, and increase flexibility, productivity, and effectiveness. I'm not gonna read the whole thing, but as you all know, a lot of our institutions are putting forth statements such as this one and policies. And my hope is that the people involved in these organizations, such as myself and a lot of you, actually live up to this and do the work to really make this a reality. You can go to the next slide. So the value statement, whatnot. This is another one of the AAN snapshots. You can go on to the next slide. Additionally, there is an inclusion, diversity, equity, anti-racism, and social justice, or ideas, group in the society. And we typically meet in the spring of every year, or an annual meeting. And there's an inaugural healthcare equity symposium occurring Monday, April 19th, 2021, which I will definitely be participating in. And it basically talks about not only treating our diverse population, but also a lot of us on the healthcare side do not really fit the bill or look like what a lot of people envision a physician to be. I can't even tell you how many times I've gone into a room and gone through the trouble of sitting down, explaining everything, whatnot, and then the patient go and complain that no physician has ever stopped. Like, nobody's been in here today, even though I have my white coat, I have my credentials, everything. I introduce myself. And I know I'm not the only one, especially in neurology. You know, we've gone way past the Caucasian older man with a little bow tie and whatnot. There's a lot of women, a lot of different races, ethnicities involved, and this is great, but we need to make sure that we're all at the table and included so that our patients may benefit from it as well. You can go on to the next slide. So the other big organizations that I'm involved in, since I am an epilepsy professional, is AES and ACNS. And like I mentioned, everybody has put forth a statement and whatnot. And there was a DEI task force appointed the spring of 2020 for AES and a position statement. And the one part I want to highlight is that we really believe that equitable access to epilepsy care and broader healthcare, it's a fundamental right. I mean, this should be part of all members of society. It is not supposed to be a luxury and just for some people. So this is very important work that we're trying to accomplish at all levels. And you can go to the next slide. So I want to highlight, for example, the American Clinical Neurophysiology Society. This is part of the agenda of the Diversity and Leadership Symposium that took place. And I know Dr. Hyder is here as a part of our audience, and she took part in it. Something that a lot of people don't realize is that a lot of minorities and underrepresented groups do want to do the work, but if we're not at the table and not included, we cannot actually make change if the people in leadership just look a certain way and there's no buy-in from them, you know? We talked about topics of diversity in neurology, how to move towards a more integrated workforce, the challenges of physician moms and underrepresented minorities. And that was Dr. Hyder, and I check off all those boxes. And I can tell you, a lot of people don't stop and realize how hard it is whenever all your intersectional kind of identities kind of prevent you or make it even harder to attain the goals that a lot of your colleagues have, just because you're a woman and you're Black, or you're like myself, I'm brown and diverse. I have a little bit of everything. I'm Puerto Rican, my first language is Spanish, I'm a woman, I'm a mom. And you know, I think that since I check off all those boxes is the reason why I care so much about this. I think people, whenever they put themselves in the position of others who might not be part of the overwhelming majority, we're better able to see how other people may experience life and how we should make sure to make it easier for them and help them out. I mean, we're all equal. So you can go on to the next slide. So to summarize, our patients, as you know, are highly diverse. They all deserve equal care. Like I mentioned before, healthcare is not a privilege. We really want to provide it to everyone. There's a lot of obstacles to overcome. I'm glad there's a lot more people involved in this nowadays, and there's momentum, but there's a lot of work to do, and we do realize this. And I do want to emphasize that, like mentioned previously, not everybody completely believes that these are actual issues. And I know from recent activities we've had on campus and extracurricular ones I've done, you can even tell by the body language that people who do not identify as one of these underrepresented classes don't really necessarily believe there's systemic racism and that they're doing anything wrong, and they actually feel like they're being attacked for, are you calling me a racist? And we go, no, everybody has racism to some degree. The importance is acknowledging it, learning, and trying to move past that, especially whenever you're in the service industry or in healthcare, because that's going to affect how you provide care to the patients, you know? And it should be more a part of the medical school and healthcare curriculum, because it really, really, really affects healthcare outcomes in all our patients. So I'm trying to achieve literacy in the diversity of social, cultural, racial, gender, and also the LGBTQI+. We need to understand how we're the same, how we're different, what matters to them, and how to provide better care for them. We need to keep in mind that not all our patients have the same level of education or socioeconomic status. We need to know that there's a big mistrust of the healthcare system. And I mean, it just makes sense. But we need to go past that and ensure that we build good rapport and trust in our patients so that they're more compliant. If they understand, they'll be more compliant. They'll be more likely to follow up. People always say, oh, lost to follow up, or, oh, this person comes to the ER a lot. And like mentioned before, that's a lot of minorities, including Blacks and Hispanics, who through no fault of their own don't understand what it means to have a seizure disorder and how it's important to take their medication and do certain things if the person who's taking care of them doesn't take the time to explain it in lay person's terms and just uses words that they wouldn't understand and doesn't realize that we need translators and make sure that they understand what we're saying. A lot of times, you know, we have the educational information in English and they hand it to the patient and they're like, well, I can't read, or I don't speak English, kind of thing, you know, and then it's completely lost. So we are working at every level to ensure that our healthcare workforce actually reflects the diverse population we serve. I know one of the sites I work at, we work the underserved population, and a lot of them don't trust, you know, oh, you have seizures, you failed more than 2 meds. I think the next approach would be, you know, doing a pre-surgical workup. And they're like, wait, you want to cut my brain? Why am I going to trust you? You know? And a lot of that is in the delivery and in the understanding. So my goal is that through all of these efforts, we're able to get everybody on board and provide better care for everyone. I hope I didn't go too overtime.
Thank you so much, Dr. Alick. We really appreciate it. I would like to have all the speakers cut on their video and would like to really make sure I say thank you so much for everyone's presentation. We are right at time. So where I was hoping we would be able to have a discussion, we're actually probably not going to be able to do that because we are right at time. And we do actually have something coming after this. But I want to make sure that everyone has an opportunity to put their email address, if they would like to, into the chat. I don't know how many of you have been able to have the opportunity to look at the chat, but it has been very, lit up actually in terms of the aspect of everybody's presentation. People were asking questions about the aspect of, you know, what you talked about. It resonated with them. They want to learn more. They want to connect with you. So if you do not mind, please put your information in the chat because of the fact that we want to make sure that's shared with everyone. Everyone who was a speaker today was asked to be a speaker because of the perspective that they bring to this particular topic, but they also want to be a resource. They want to be able to connect with you. They want to show you and discuss how did they do what they're doing, and then how are they able to help you to be able to do the same. I want to thank you so much to every single one of you for taking the time, for being able to share your perspective, putting those slides together, but also giving so much encouragement. There's so many people on the call who they really were able to understand exactly what people are going through because of what you shared, but also the aspect of how they can do the work that needs to be done. So I want to say thank you so much to every one of you. Please do connect with us at the Epilepsy Foundation. Tomorrow, we will continue our work with National Public Health Week and offer a seizure first aid training. As Tonya mentioned, thank you so much for mentioning that. We do offer those for free. We do twice a month. They are national trainings that you actually do get CHES credits. You get 2-year certification. And tomorrow we are doing one at 3:30 Eastern Time for National Public Health Week, and the other dates are listed. So with that, I want to say thank you to everyone. And then if anyone else, one of our speakers would like to say something, just as a parting words, I would like to give you that. And I want to make sure that everyone knows if you are seeking credits, then you must complete the survey that comes after this webinar. The link will be put into the chat, and the link will be sent out to everyone who registered for the webinar. But if you want those credits, you must complete the actual evaluation before the end of this week. With that, anyone would like to give some parting words? You can just unmute yourself. No? I understand that too. You all said it all. Oh, Dr. Dennis, go ahead.
I just thank everyone for speaking, presenting, and for everyone for attending. This is real work that's not always comfortable, but let's keep doing it.
No, thank you so much. I appreciate all of you. And I am extremely grateful. I will say that I look at it as an honor and an opportunity to be at this table to try to make change. And for whatever table you all are at, please do the same and make sure that you're inviting others to those tables and to those spaces in every single day. So with that, I want to make sure I say thank you. We do have some information about how to get in contact with us. Cheryl, if we can get that last slide, please. And this is how you can connect with us nationally. So please do provide information at programs at efa.org. That is an opportunity for you to be able to connect with us on a national level, and we can get you exactly the information that you need. Also, if you are seeking services around epilepsy or seizure support, our helpline is 24 hours, and it is also offered in Spanish. So please send that to anyone who may be in need. We do not only just provide information about your physical health, but we do look at those social determinants and try to connect people with all areas of what they're dealing with in terms of their wellness. And then, of course, all of these resources are also included on epilepsy.com. So again, I want to say thank you so much to everyone. Enjoy your day, and we will see you guys next time. Please enjoy National Public Health Week. Bye, everyone.